Actually, it is not a debate because it's my feeling, and I think globally this is what we have been experiencing, that the two specialties now are not moving in parallel, but their paths are meeting somewhere in the middle. And hopefully this joint presentation will convince you about that. So it's not versus, it's or, and it's about patient selection. And I think the previous presenter, Michalis Chrysoheris, has elaborated a lot on the guidelines and the selection criteria. It is true that mitral disease is very prevalent these days, possibly more than aortic, and the forecast is that the incidence will double by 2040, and this is also the clinical experience we get on every day. Gold standard for degenerative MR is surgical repair with excellent outcomes up to 20 years, and early management possibly offers a lot of benefit. But when it comes to functional disease, surgery is probably not a good idea because undersized annuloplasty hasn't delivered the goods. It hasn't provided any durable effects on the mitral function, and unfortunately hasn't provided with any good evidence in terms of follow-up. So this unmet clinical need is being met now with leaflet therapy and of course various other transcatheter therapies. And of course we have TMVR, who has been struggling really to produce any good clinical outcomes, and I will elaborate on that in a minute. You've seen these two devices, MitraClip, mimicking surgical edge-to-edge therapy. This is a typical patient, functional dilated cardiomyopathy, functional regurgitation, big coaptation gap in the middle, huge MR. Patient is grossly symptomatic. And with two clips, NTW clips, one in the middle and one medial to that, we have an excellent result. You can see the second clip, both of them generation 4 NTW. Patient is mobilized rapidly, is sent to the ward on the same day, going home the following day. And this is pretty much the reality these days. This is the result. And this is a more complex patient, 88-year-old, prohibitive surgical risk, flail anterior leaflet, but also restricted posterior leaflet. Very challenging case. Still, we can deliver, and with some difficulty, you can see how torrential with 3 clips, 3 XTW clips actually, to hold the anatomy, we were able to have this good result. The patient is better. So the MitraClip now has a path of almost 20 years. And from the Everest trial with the first generation device, we have gone to the QUAP trial with excellent outcomes up to 3 years, both in hospitalization as well as mortality, which is very important since it's the only device therapy that has shown mortality benefit in patients with functional mitral regurgitation so far, and an impressive number needed to treat. We have been used in the old days, all of us that have been treating patients with CLIP, to follow the Everest criteria. And in fact, if you follow the criteria, this will be a guaranteed success. So flail gap of less than 10, flail width of less than 15 millimeters, and some coaptation and not an excessive tenting height in functional cases. Yes, you can have a success rate of 99% plus. But we have moved to from the left column to the middle column, that if you have a pathology in the commissures, yes, we can treat that. If your valve area is not over 4%, but is over 3% with potentially not a lot of calcification, potentially you can deliver some treatment. If your posterior leaflet is restricted and short, it has been a no-no in the past, but yes, we have devices now that they can treat that. But what about the patients on the right column, the patients with the calcium, with the rheumatic disease, with the mitral stenosis and regurgitation, with very short and akinetic posterior leaflets? These are the patients that leaflet therapy can actually not address. The guidelines you have seen for functional coapt patients and for high-risk degenerative patients, MitraClip is now the gold standard. And I think you cannot debate that anymore. Any therapy for these patients, unfortunately or fortunately, will have to be compared with that if the guidelines are to change in the future. You've seen the Gen 4 with the independent grasping capabilities, the same with Pascal device. And here is what we're doing at the moment. This is a patient that had a repair for a flail P2. There is a ring, but there is also calcium and there is a thickened subulvar apparatus. And these patients cannot be treated again with another surgery since the patient is high risk. The problem is not the residual mitral regurgitation, it's also the hemolysis that this patient is having, something that we don't see in the transcatheter therapies, but we do see in the surgical therapies. And we went to treat this patient with another clip. So an NTW clip was positioned in the P2. There was enough room to put it, and we didn't create stenosis. This is the clip that grasped the area. And with modest result, to be honest, there was significant reduction. The LA pressure fell from V wave to 50 to a V wave of 20 millimeters of mercury. But most importantly, within a few days, the hemolysis disappeared. The LDH from 1,600 fell to 400. So patient actually recovered very well from this and had a very good result. This is another scenario that we commonly see these days, a degenerative mitral bioprosthesis with a lot of stenosis. You can see patient has been terribly symptomatic for at least 3 years, not making any decision to go for transcatheter therapy. And this is the huge issue that we're facing when it comes to replacing the valve via catheter. What will happen with the neo-LVOT? Now, the neo-LVOT clearly is a big issue. Here, we were lucky enough to have a projected neo-LVOT of significant area that we were able to put a transcatheter valve. And this is what we did. We went there transeptally. We implanted a balloon expandable valve, as you can see, with a very good fit and an excellent result. There was no gradient, you can see. There was a trivial PVL and an excellent mitral valve area. But that's not always the case. You have ring cases, patients that have been operated with rings, and most importantly, patients that have MAC, mitral annular calcification. That is a huge problem both for conventional surgery as well as transcatheter therapies, because usually these are the patients that are old, that have a thickened subvalvular apparatus, a narrow LVOT, and these are the patients that are very difficult to treat with a catheter. We have other devices like the Carillon device that has been around for many years. We have experience with that because we participated in the trial, and you can really undersize the circumference of the coronary sinus and have variable results to the degree of mitral regurgitation, potentially affect the geometry of the patients. We have the neocord devices around that have been used here in Greece as well for prolapses, of course, with very highly selected population. And we have TMVR. Actually, the TMVR is this device, Tendai. It's transapical, the only approved CE mark device to the best of my knowledge. It's high bore, a lot of French on the catheter. Again, limited selection of the patients. I've been told that less than 30% of the people that are referred are actually eligible for this. And it has produced good results on the trials. I'm not very sure whether the mid or long-term outcomes are equally the same. Of course, there are more devices coming. Most of them, and the focus is for them to be transeptal, transfemoral. And of course, this, if works, if there is an iteration that will be able to deal with all the issues, the fixation issues, the neo-LVOT issues, and the calcium, that could mean a big development forward, but it has to be seen. So in conclusion, the transcatheter options, mainly leaflet therapy, is the new gold standard for functional MR patients, secondary MR with dilated ventricles, coapt-like patients, also for high-risk patients with degenerative valves that cannot be operated and then they meet the suitability criteria for clips. But we do have valve-in-valve, valve-in-ring, valve-in-MAC patients that can be potentially suitable, like the patient that you saw, for transcatheter options. But again, we're limited with the neo-LVOT and the calcium. TMVR is an emerging approach, but it has been a struggle for the industry to produce devices that can be reliably applied to a big proportion of patients. So it's a field that is moving forward quite rapidly. There are lots of companies that are being activated at the moment, lots of trials to be seen. But what we cannot achieve via catheter, we can certainly achieve in the operating room, and the surgeons have moved quite a lot in that field. And it will be very interesting to see what my colleague will have to say about that. So thank you very much for your attention.
Thank you very much for being on time. And it's now the term